Welcome back. In this video, we'll be learning about organophosphate poisoning, its clinical relevance and its mechanism of action, and what are all the symptoms and its treatment and diagnosis. At the end of this video, there is an MCQ that has been repeated in the previous FMGE exam, and it's for you to solve. So let's begin right away. So what are organophosphates? Organophosphates are organic esters of phosphoric acid which are widely used as insecticides. So what's the clinical relevance behind this? Since it is a chemical compound, it has to be produced and consumed. So here are the two most vulnerable groups, the workers who are involved in the production and the consumers who are farmers. Assuming that the industries provide enough protection to the workers, farmers are being widely mentioned. Let's just run through the three ways that a person could be affected with OP poisoning. One is via ingestion, the other is inhalation, and the other is dermal absorption. Providing awareness to wear masks and eyeglasses to cover their face and gloves while handling the organophosphate compound is really helpful in reducing the chances of OP poisoning. In this slide, we'll understand how does the normal acetylcholine neurotransmission occurs and what happens or what changes that are brought when a person is under OP poisoning. In the normal, this could be a nerve ending that has stored acetylcholine in it and it's ready to release once the action potential comes. And the below one is an end organ or another nerve that has the corresponding receptor for acetylcholine. Once the action of acetylcholine is complete, there is an enzyme called acetylcholine esterase that is ready to break down acetylcholine into acetate and choline so that the acetylcholine does not overact and there are no symptoms of parasympathetic overaction. So, in the OP poisoning, what happens? This could be the same, a nerve ending, this could be an end organ or a nerve ending. The acetylcholine is released on action potential. Once the action potential comes, the acetylcholine is released and it begins to act on the receptor. So once its action is complete, normally it should be broken down by the acetylcholine esterase. Here, the organophosphate comes and bind to the acetylcholine esterase irreversibly so that the acetylcholine is not broken down and it's circulating over and over in the same area, activating the receptor, thus creating a condition of parasympathetic overstimulation. Using the piece of information that we have learnt on the previous slide, I want you to understand the classification, identify where the organophosphates are placed. Here, so we have learned that organophosphates irreversibly inhibit acetylcholine esterase. Imagine what happens when it does. So, the acetylcholine levels are increased, meaning to say it is cholinergic. Thus, you have read the classification. Organophosphates irreversibly inhibiting acetylcholine esterase, and it is a cholinergic agent. Therefore, it comes under the class of drugs acting on autonomic nervous system. This is the classification of organophosphates. Proceeding with that, we'll learn what are the organophosphate compounds. Organophosphate compounds can either be insecticides or nerve gases. The examples of insecticides are malathion and diazinon, and the nerve gases are tabun, sarin, and so on. The mechanism of action is irreversible acetylcholine esterase inhibition, leading to cholinergic symptoms. Whenever you're suspecting a case of organophosphate poisoning, these are the symptoms you will be looking up to. There will be muscarinic symptoms and there will be nicotinic symptoms. In the most cases, both will be combined. Now, I want you to go through with all the symptoms. I'll just explain whatever is difficult or it is contrasting to remember. Here, you can see sweating. Here also you can see sweating and hypertension. These symptoms are classically under sympathetic overstimulation. Here it is given not to confuse you. There is a mechanism behind that. So, in case of nicotinic overstimulation in the sympathetic nervous system, this is a presynaptic nerve ending and this is a postsynaptic nerve ending. Here, there are nicotinic receptors which are stimulated by acetylcholine. So, when there is OP poisoning, these sympathetic nervous system is overactivated, leading to symptoms of hypertension and sweating. And also, sweating is given under the muscarinic symptoms. How does it so? Consider this as a sweat glands. Sweat glands contains muscarinic receptors which are stimulated by acetylcholine. So in the case of OP poisoning, there is acetylcholine excess leading to excess sweating. So sweating is a symptom is both under muscarinic and nicotinic. Hope that's clear. I want you to pause the video and go through all the rest of the symptoms. If you have any questions, comment down below. Let's proceed. Now, when do you suspect a case of OP poisoning? The diagnosis is usually clinical. When I say clinical, it means you have to extract the occupational history of the patient or any significant exposure to the insecticides or organophosphates and the classic muscarinic and nicotinic symptoms that we have just discussed. And if you have to confirm OP poisoning, you could either do a plasma or RBC cholinesterase test. What is the treatment? You can decontaminate the patient, and the classic treatment for OP poisoning is atropine. And how do you remember that? When you spell atropine, you can see that TROP could be remembered as treatment for OP poisoning, which makes life much easier. And you can also give pralidoxime. What you have to remember about pralidoxime is it is best given within 48 hours, and I'll be just explaining how does it works. Now let's proceed. How does atropine work? Atropine comes under the class of competitive antagonist at muscarinic acetylcholine receptors. Let's just see what's the mechanism of action of atropine. Whenever an action potential comes, the acetylcholine is released and it's ready to act on its receptor. In case of organophosphate poisoning, you can see that the enzyme is irreversibly bound to the organophosphate. But here is a state of acetylcholine excess. The atropine comes and competitively binds to the receptor, preventing the acetylcholine from binding to its receptor, therefore reducing the symptoms of parasympathetic overstimulation. I hope that's clear. Now let's proceed with the next drug, pralidoxime. In the previous slides, I have mentioned that pralidoxime is best when it's given before 48 hours. The 48 hours window period is when the organophosphate becomes irreversibly bound to acetylcholine esterase. We call this as enzyme aging. So, in a simple sentence, pralidoxime is best given before enzyme aging. So what does pralidoxime does? The pralidoxime removes the organophosphate which is ready to become irreversibly bound to the acetylcholine esterase, therefore bringing back the acetylcholine esterase into action to do its normal function. The mechanism of action can be stated as reactivates acetylcholine esterase inhibited by organophosphates in OP poisoning. Here comes the last slide and the MCQ for today's concept of OP poisoning. The question says, what is the most sensitive test for organophosphate poisoning? And the options are plasma acetylcholine esterase test and organophosphates in blood, organophosphates in lavage, and the last option is organophosphates in urine. I want you to analyze this question. You can answer this question in the comment section, and I have also given the answer with explanation in the comment section. I want you to go through it. That's all for today. Like this video, share this with your friend, and subscribe to our channel for more videos. Let's learn pharmacology one drug at a time.